Hi, everyone. In case you're just joining us, I'm going to reintroduce myself. My name is Eric Cal. I'm a physician at the Keck School of Medicine of the University of Southern California, and also a member of the Board of Directors for the Scleroderma Research Foundation. I'm pleased to introduce our second forum topic for today, gastrointestinal involvement in systemic sclerosis. Before we begin, I have just a few housekeeping details. And if you were here for the first session, you may have already heard this, so bear with me. During the presentation, you can submit questions during the entire session in the Q&A panel on the left side of the screen. At the end of the presentation, the moderator will select a few questions to answer live. Any questions we don't have time for will be answered via direct message or by direct email after the forum has concluded. There'll be a short survey at the end of the Q&A, and then after a couple of minutes, the third session will automatically begin. Please note that following the third session, there will be a 20-minute intermission. You can step away from the screen and stretch your legs, or feel free to stay here and check out some video content we have to share with you honoring Bob Saget and more. Now I'd like to introduce Dr. Zsuzsanna McMahan. Dr. McMahan is an associate professor of medicine in the Division of Rheumatology at Johns Hopkins University. She joined the Johns Hopkins Scleroderma Center as full-time faculty member in 2012 and has been an integral member of that team ever since. Dr. McMahan has focused her time on clinical and translational research relating to the gastrointestinal complications of scleroderma and caring for patients with scleroderma. Her research is being funded by the National Institute of Health, and she also has a long history as a funded researcher of the Scleroderma Research Foundation. Dr. McMahan co-leads the International Scleroderma Clinical Trials Consortium Gastrointestinal Working Group with Dr. Elizabeth Volkman, and she is integrally involved in the leadership of the American College of Rheumatology, where she currently is the clinical chair of the International Annual Scientific Meeting. It's my pleasure to now welcome Dr. McMahan and introduce her session on GI involvement in systemic sclerosis.
Thank you, Eric, for the introduction. I'm Zsuzsanna McMahan, and for the next 20 minutes, I'll be focusing on the evaluation and management of dysphagia and gastroesophageal reflux disease in scleroderma. I have no relevant disclosures, but I will be referencing off-label uses of medication. So today our objectives will be to review the gastrointestinal manifestations of patients with systemic sclerosis or scleroderma, specifically focusing on dysphagia or trouble swallowing and gastroesophageal reflux disease. We will discuss key strategies used to evaluate esophageal dysphagia and scleroderma-related gastroesophageal reflux disease, and we will also review relevant management strategies. So the gastrointestinal complications in patients with scleroderma are diverse. As you can see in the pictures listed, patients may present with a variety of symptoms, and you may have symptoms of acid reflux or burning in the throat, as you see in the upper left. You may have scarring or have trouble swallowing food because of an obstruction in the esophagus that results from chronic exposure to acid and scar tissue. You can have dry mouth or xerostomia, seen on the bottom left, dysphagia or trouble swallowing from calcinosis or other reasons, GAVE or gastric antral vascular ectasia, which is also known as watermelon stomach, which can cause bleeding, or dysmotility in virtually any part of the gut, which can include the small bowel and colon. You can see the large dilated loops of bowel on this patient's CT scan in the bottom right. All of these can have a major impact on the quality of life of patients. And the evaluation and management is important to discuss for a number of reasons. First, gastrointestinal dysfunction often impacts most of a patient's disease course. Gastrointestinal dysfunction can impact sleep, fatigue, and quality of life. Patients may be asymptomatic and still accumulate damage within. And then finally, many of the symptoms are nonspecific. And so it's important sometimes to identify where the symptoms are coming from so that therapies can be appropriately targeted. There are many causes that can contribute to gastrointestinal symptoms in patients with scleroderma. Some of those include things that affect the general population, including side effects of medications, changes in diet, as well as disruptions of the microbiome. And some patients may experience trouble with transit, as I mentioned before, or food traveling from the esophagus to the colon, which is usually a consequence of scleroderma. For the purposes of the next 20 minutes, we will focus primarily on transit as a complication of scleroderma, as well as dietary modifications that may be able to help control symptoms. So gastroesophageal reflux disease is really common among patients with scleroderma. It affects up to 90% of our patient population. Symptoms may include heartburn, acid reflux, regurgitation, cough, hoarseness, laryngitis, and then sometimes there are no symptoms at all. Over time, this exposure to acid in the esophageal tissue, which is very sensitive, can result in bleeding, strictures, which are also another word for scar tissue, esophagitis or inflammation of the esophagus, and Barrett's, which is a precancerous lesion. Furthermore, not controlling upper gastrointestinal symptoms has also been associated with worsening of lung disease in patients, which is clearly a very concerning outcome that can lead to a lot of morbidity or complications in the long term. The initial approach to symptom management of gastroesophageal reflux disease is probably something that many of you are already familiar with. Lifestyle modification is definitely one of the first steps that we consider. In terms of diet, what are you eating? And then habits, what do you do after you eat? Both of these things can really impact symptoms, particularly in patients with a dysfunctional esophagus or upper GI tract. Eating early, trying to limit food intake to more than 4 hours before lying down. Both of those are important. Elevating the head of the bed to try to minimize episodes of reflux, as well as eating smaller meals can all have a positive impact on symptom control. The timing of the meals can also be important, dividing meals up throughout the day into short, small meals that occur multiple times throughout the day rather than 3 long, large meals. In terms of exercise and weight management, these are, of course, highly relevant as they are in the general population. And then avoiding triggers such as alcohol and smoking are also very important. There are many types of foods that can aggravate symptoms of GERD in patients with scleroderma. Fried foods, fast foods, pizza, potato chips, all the good stuff can all cause trouble with symptoms. Chili powder and spicy foods, fatty meats, cheese can also cause trouble, as well as tomato-based sauces and citrus fruits, citrus-based sauces, chocolate, peppermint, and carbonated beverages. So these are important foods to try to minimize if you're having symptoms of GERD that are uncontrolled. There is some good news, however. There are some foods that may help with gastroesophageal reflux disease. Alkaline foods, or foods that run kind of on the opposite spectrum of acidic foods. These are called alkaline foods, and they can include bananas, melons, cauliflower, fennel, and nuts. And all of these all of these foods can help to offset strong stomach acid and may help to improve symptoms. Furthermore, eating foods that can contain a lot of water can dilute and weaken stomach acid. Some of these foods include celery, cucumber, lettuce, watermelon, broth-based soups, and even herbal teas. There are several home remedies that also may help symptoms. Milk comes in a variety of fat content subtypes, and the whole milk version of milk can definitely aggravate symptoms of reflux because of the fatty content. However, non-fat milk can actually act as a temporary buffer between the stomach lining and the acidic stomach contents and provide immediate relief of heartburn symptoms. So this is something to consider. Low-fat yogurt may also have a similar soothing quality. Ginger is one of the best digestive aids just because of its medicinal properties. It's alkaline in nature and anti-inflammatory, and this can ease some of the irritation in the digestive tract as well. Sipping ginger tea may be helpful in controlling symptoms. And while there isn't enough research to prove that drinking apple cider vinegar truly helps, many patients find that it can be helpful, so it's worth a try. However, you should never drink it at full concentration because it's a strong acid and it can irritate the esophagus and make things worse. So instead, you should put a small amount into a warm water beverage and drink it with meals. Lemon juice is also considered very acidic, but in a small amount can be, again, mixed with warm water and honey, and can have an alkalizing effect that can, again, neutralize stomach acid. The assessment of gastroesophageal disease is important. The first line intervention is usually an upper endoscopy. It is recommended by the American College of Gastroenterology as a tool for assessment of refractory gastroesophageal reflux disease in patients who have failed a trial of proton pump inhibitor therapy or other antacids. In patients with red flag or atypical symptoms, such as bleeding or in the stool or vomiting blood, it's usually a first line intervention. It is used to assess the mucosa or the lining of the esophagus and the stomach, and it can identify hernias. It can also identify inflammation from esophagitis, which can result from chronic acid exposure. It can identify Barrett's esophagus, which is a precancerous lesion. It can identify fungal infections such as Candida or eosinophilic esophagitis, which can also cause symptoms in patients with scleroderma. If there are signs of reflux or symptoms of reflux, oftentimes a proton pump inhibitor or H2 blocker will either be initiated or added to the existing therapeutic regimen to try to obtain better control of disease. If patients still continue to have symptoms of gastroesophageal reflux disease despite therapy with acid blockers, pH manometry with impedance is often utilized. This is a tool that is very useful in relating symptoms with episodes of reflux. Furthermore, it's usually done while on therapy, so it can distinguish symptoms that are attributable to acid reflux from symptoms that are attributable to non-acid reflux. And so, therefore, it can be helpful to determine whether or not you truly need higher doses of acid blocking medicines, or if there are other ways that should be considered for management of symptoms. And you can see in the picture on the left that this woman has a nasal tube in place, which is a probe with sensors that can detect a passing bolus of food in the esophagus, and it usually stays in for about 24 hours. And you can see she's wearing the monitor on her body, and she keeps a diary throughout this period of time, each time she has symptoms. And again, this can be a useful additive tool to better understand why symptoms continue in the right set of patients. Esophageal dysmotility is something else that we think about in scleroderma. It can affect many patients, up to 90%, and it involves slow transit or weak muscles in the esophagus. And again, this can, if food is staying in the esophagus, this can contribute to symptoms of reflux. Or if there's a weak valve between the esophagus and stomach, which is called the lower esophageal sphincter, if that's weak, then stomach acid may reflux into the esophagus in a relatively uncontrolled way. And then if the stomach is slow to empty, this can also contribute to gastric reflux entering the esophagus, because the stomach can get full and the contents can escape into the esophagus in that situation as well. And depending on where the lesion is in patients, different therapies may be indicated. The challenge is that symptoms are not perfectly associated with the regions of the gut that are affected. And because therapies differ, sometimes we need additional testing to really figure out what's going on. So just as a reminder, normal gastrointestinal motility occurs when a bolus of food enters into the esophagus and it's squeezed by muscle contractions, which propel the bolus of food forward. And the muscles line the gastrointestinal tract. As you can see here, there are two layers of muscle that help to propel the bolus of food forward. Think of it as squeezing a tube of toothpaste, and the toothpaste moves forward. The gut operates in a similar way. Esophageal dysphagia is when often occurs when there is dysmotility or slow transit in the esophagus and the muscles are weak. Patients may be asymptomatic, but many times they'll have trouble swallowing solids and liquids. They'll have regurgitation or vomiting, sensation of food getting stuck in the chest, or chest pain. And one of the ways that we can assess this and determine how significant the symptoms are and whether or not patients should be treated with pro-motility agents is with something called a high-resolution manometry study. And as you can see in the diagram on the upper left, there is a bolus of food represented in green that is passing the muscles at the top of the esophagus, which are essentially in the throat, just above the esophagus and the pharynx. And as the bolus of food enters, the muscles in the esophagus push it down until it reaches the end of the esophagus and starts to transition into the stomach. And you can see in the figure on the right, that's a representation of images from a manometry study that is often recommended by doctors to better understand if dysmotility is present. And you can see that the pressures in the gastrointestinal tract are represented. High pressures are in red, low pressures are in blue. And as the food enters the throat or the cricopharyngeal area, the pressures drop so that it allows the food to pass. And then the peristalsis is the muscle contraction that increases the pressure to push the food down. And then again, the muscles at the end of the esophagus relax through the sphincter and allow it to pass into the stomach. And so that's what a normal study looks like. In scleroderma, what can happen is that you can see one of these two patterns. One is ineffective esophageal motility, where food can pass in, and there's an initial attempt at pushing the food down through the esophagus, but they're relatively inefficient and low pressure waves, and that's demonstrated on the figure on the left. Or on the right, sometimes patients can have absent contractility, where there's no muscle pressure pushing the food through. And in these situations, you want to think about prokinetic agents that can try to get the muscle in the esophagus working, or at least initiate a trial to see if it helps control symptoms. So again, this is important because depending on the type of lesion that is affecting the patient, different types of medications might be required to control symptoms. As we mentioned earlier, if somebody has acid reflux, we usually use acid blockers, whereas if there's an issue with movement or motility in the esophagus, we will oftentimes defer to prokinetic agents, which strengthen the muscle contractions and allow food to be propelled forward when it is not happening and causing trouble. And again, there are some medications that can strengthen that valve at the end of the esophagus that are listed here. And whenever there are symptoms, it's also important to consider any aggravating medications like calcium channel blockers, which can indeed exacerbate symptoms of acid reflux. Sometimes we need the medication, so the downsides are less than the upsides, and it's worth continuing them, but it's always worth reassessing the medication list to see if there are any aggravating factors. So again, depending on where in the gut there's an issue, the treatments may vary, so it's important to talk to your doctor about this. The Scleroderma Research Foundation is interested in potentially supporting some additional work that we're doing to try to differentiate patients who have progressive gastrointestinal disease from patients who have relatively stable disease throughout their life. And you can see here that severity in some patients increases really quickly and continues to progress over time, which is seen in the diagram on the right. And on the left, patients really progress slowly over time. And in the middle diagram, it's actually an improvement over time. And so we'd really like to differentiate those different groups because they might need to be treated differently. And it would be nice to be aware of what the risks are in terms of GI progression in these patients. So in summary, gastrointestinal symptoms can arise from a variety of sources, including diet, medications, and scleroderma itself. A trial of lifestyle modifications with or without over-the-counter medications is a reasonable first step in therapy. Understanding the source of the symptoms is important when symptoms are hard to manage, and this can inform the selection of the most appropriate medications. So thank you very much to the Scleroderma Research Foundation for continuing to support me. Thank you for the Rheumatology Research Foundation and to the National Institute of Health for also supporting my research. And I will now proceed to a question and answer session. And I'd be happy to address any of your concerns. Thank you.
Hello, and thank you. Hello, and thank you all for attending. I'm Dr. Sharon Doby. I am a professor emeritus in the School of Medicine at the University of Washington, and I'm here to ask questions of Dr. McMahan. Dr. McMahan, thank you so much for sharing all this great information on scleroderma and the GI tract. And we did have a number of questions that have been submitted, and if it's okay with you, I'll start with asking you a few of them.
Absolutely. Hi, how are you?
Yeah. One patient was dysphagia. Are there any foods that help with extended belly issues?
Yeah, so avoiding a lot of the fibrous and cruciferous foods can help to minimize some of the distension or gas in the belly. So those foods are often the ones that are high in fiber that help the stool to move through the gut faster. But many times if your gut is slow, they can exacerbate the bloating. So a trial away from some of those some of those foods might be helpful for you.
Thank you. Another question was, you talked about foods that tend to exacerbate the acid reflux. What about caffeine?
So caffeine is definitely, sadly, one of the triggers that can exacerbate acid reflux. Same with all the chocolate and alcohol and all of those goodies. Pasta related with red sauce can also do it. And so caffeine is sadly a trigger. I try to not be extreme, and I don't recommend complete abstinence because that would make me a crazy person myself. But
Right.
But if you can reduce the amount of caffeine that you take in each day, that could potentially help your symptoms.
So Terry asked that she has a hiatal hernia, and what impact might that have?
So hiatal hernias can exacerbate the symptoms of acid reflux. And a discussion with the gastroenterologist is important to have, as depending on what type of hiatal hernia you have. Sometimes it needs intervention and sometimes it doesn't. In general, if it's a sliding hiatal hernia, conservative management and management with medications as well as weight loss are all good approaches to try to help reduce symptoms of GERD.
Great. And Susan says she has gastric aspiration at night. And what's the quickest way to relieve the pain? She says her head of her bed's already elevated. She doesn't eat after 5:30.
Yeah, that can be really miserable. I would recommend actually not waiting until you have the acid reflux episodes at night to treat it. You probably need to, if you're not already on medications such as proton pump inhibitors or H2 blockers, then I would probably start taking one more regularly. It didn't seem like in the chat that was something that you were already taking. If you are already taking those medications, then you could potentially have a study done, such as an esophageal manometry study with pH testing, to determine whether or not your acid suppression is adequate, and whether or not a pro-motility agent might help you reduce the symptoms.
And she said she had the head of her bed elevated. What about What about the wedges that you can buy?
Yeah, absolutely. Some people have the fancy bed with the buttons and the head of the bed goes up. Others put cinder blocks under the head of their bed and lifted it up. That way, the wedges are a great alternative. You can get fancy wedges, inexpensive wedges. There are all sorts of things on the market to help with GERD, since it fortunately or unfortunately affects most of the US population.
Right. What about, Valerie asked about almond milk decreasing acidity. Does it?
Yeah, I don't really have anything in particular to cite specific to almond milk. I'm always a proponent of trying it, especially if it's a lower fat alternative to other things. And so if you try it and it helps, I think it's reasonable. It's not going to hurt you.
Okay. And Nancy asks how Reglan helps with swallowing.
Sure. Reglan is a pro-motility or prokinetic agent that helps improve the muscle strength, I guess, in your esophagus. It acts on dopamine 2 receptors, which basically means it inhibits those, which improves motility, and it also acts on some serotonin receptors as well. And both of those together move food better down the esophagus.
Great. I'm just looking at some other questions. Can you say a little bit more about the acid reflux and the effect on interstitial lung disease?
Sure. That's a really interesting area of research right now. There's quite a bit of data showing an association between uncontrolled acid reflux and progression of interstitial lung disease. And so we think that at least in a subset of patients, uncontrolled acid reflux may exacerbate a patient's course with interstitial lung disease, not necessarily every patient, and we're still trying to determine who those high-risk patients are and what are the risks that would cause somebody to have more episodes of microaspiration to potentially cause this type of damage. So there are a lot of unanswered questions there, but I think the main point is that controlling the acid reflux in the first place is really important and should be something that you and your doctor take seriously and work on together as a team.
What about the patient who has lung disease doesn't necessarily have symptoms of reflux? Would you treat them in a preventive way?
So that's another really great question that we need to study. And it's definitely been raised among people in this field. And there are a couple of us right now, Dr. Volkman and I, she's at UCLA, are working on putting together a grant proposal to potentially look at this. Right now, because manometry is kind of an invasive test, we often don't look ahead of time to see if someone's got motility problems or problems with the function of their sphincter. When they're asymptomatic, we could do something like a barium swallow to see, as that's less invasive. But whether or not it's beneficial to treat the asymptomatic reflux and in which patients that would benefit is also unclear. And so there are several areas that still need to be studied in that area.
Yeah, it kind of goes along with what Sue said. She said, if GI issues can be asymptomatic, how's the best way to monitor for issues? And I think you kind of addressed that.
Yeah, I mean, you can, if you're really worried about it, you can do screening studies. Some people would argue that, oh, well, every patient could have an upper endoscopy when they're diagnosed with scleroderma to screen for, erosive esophagitis. Other people would say, no, that's an invasive study. We should wait till somebody has symptoms before doing a study like that. And so you can kind of find opinions along the spectrum. And whether or not you decide to look for acid reflux early and treat it prior to symptoms is something that you would need to discuss with your physician. There's not a strong line of evidence that directs you in that regard.
Okay. And what are the best times to take acid reflux medications?
Well, for the proton pump inhibitors in general, for most of them, you need to take them 30 minutes before you eat because they're activated by the acid that is secreted with the ingestion of food. And so there are a couple of the newer agents in the proton pump inhibitor family that don't require that timing specific ingestion. But in general, that's how you need to take those meds. I think the H2 blockers are less sensitive to timing with meals.
I think we maybe have time for one more question. Can you speak about rectal prolapse?
Sure. So rectal prolapse is definitely something that we see in scleroderma and in the general population. And in general, a pelvic floor weakness or pelvic floor dysfunction can affect patients with and without scleroderma. And rectal prolapse itself can exacerbate lower GI symptoms that patients are experiencing. So in general, that's something that should be addressed prior to really going to more aggressive therapy for, let's say, incontinence or constipation.
Thank you. Dr. McMahan, I think this is all we have time for today. And for those of you watching, if you asked a question and we didn't get to it, we will get back to you and follow up with you offline. So thank you for joining us, and I hope you enjoyed the next session. And Dr. McMahan, thank you again.
Thank you, Sharon. I appreciate it. And thank you to everyone.